usually they meet people who are not qualified to work on them, who always carry these patients, take them to nearby facilities, usually clinics, with the aim of commission. So we have a lot of complications that come, not because patients actually reach the hospital in time. When they reach hospital, they are always lied to by strangers. Someone comes and says, I'm sorry, I'm going to take you to a place where I'm going to help you very fast. So because these people are desperate, they're in pain and they need, they always end up going somewhere where when they reach there, they actually charge a lot of money, and some of the money is commission for these people who act as brokers. And this is more common. Why is there are a lot of facilities actually just immediately outside the hospital gate. Then to make matters worse is you find that the investigations, for example, imaging, x-rays, we have a very good x-ray in main hospital which is 15,000 shillings. But a patient goes out of the hospital, does an x-ray at 40,000, 6,000 shillings. The x-ray not even capture what's important, it's very poor in quality. And when the patient comes to main hospital to you, you tell him, I need another x-ray. So these are things that, of course, we've raised these issues to the administration, we've discussed at the department level. I do not know how I don't know how they're going to handle that, but that is actually the situation that we are in. We've tried, and next matter worse is some patients are mismanaged that you actually have to remove the leg. Of course, you feel bad. Some scenarios we also see reach the administration, but in the end, I think nothing is done. So it's reached a point and now kept quiet. We just wait for those who come, you handle. Those who don't, you just pray they don't fall into wrong hands. Yes, so very many. And so actually we had a scenario where a patient was actually charged a lot of money for putting a cement on the leg. This patient got a condition called compartment syndrome. It's an emergency. So after being worked on, the patient was sent home. The patient comes back from home when the limb is dead. When we told the patient that we have to amputate the leg, the patient actually asked me if I'm to quote his words. Said himself, because to him in his wildest dreams he couldn't imagine that a simple breaking of the bone could lead to removing the leg. So when I told the patient and the caretakers went up in arms. They carried their patient and they took the patient to Orthopedic Surgeon. When the patient reached there, the head of the facility called us and asked us, what's happening? Why is the patient of a simple amputation moving all this way? So he had to explain. So it took convincing to have the patient amputated, because the patient thought, the patient was saying, I came to main hospital, you mismanaged me, now you want to remove my leg. And yet the people who did this are actually not qualified to do so. They got the patient, took him to one of the clinics nearby, and they did whatever they did. So by the time we found the patient, it was too late to intervene. So those are some of our scenarios. Usually when patients come to casualty, the facilities outside have brokers here. So when they come, usually the lies I've had is there are no doctors who work on bones in main hospital. So when they come, they say, no, you're going to stay here for long. There's no doctor to see you. Let me take you where the doctor is. And one of the hospital ambulances has I don't know what it's called. Is it a cost or something?
Yes,
of the facility?
Yes.
So the ambulance driver comes, picks the patient, and is escorted by one of the askaris up to the facility, where when they reach, they are given commission. Even borders tell you that, hey, you know that place, the moment you reach with your patient like this, they give you your money to thank you for bringing the patient. And these things are going on. We know about them, but we don't have the power to stop what's happening. So we always wait for those who come. Those who are complicated, we manage. Those, Self-medication is a challenge in Uganda. Why? Our council has failed us. You know, in Uganda, there is no limit to who prescribes what. You find someone is a nurse, they don't know what they are. They don't know the drugs they are giving, but for them, anyone who comes, I've seen very many times where, right now, if we went to casualty, you find a patient has a fracture with no wound at all, but the clinical officer writes painkillers, writes antibiotics. Now, if someone has no wound, why do you give them antibiotics? But these are people who government has employed. They have been put in place to manage patients, and they do not know these simple principles that if someone doesn't have a wound, please not give antibiotics. So I don't know whether it is the training in schools that is failing. I don't know. But the challenge we have is we do not control who prescribes what. That is why we have a lot of drug resistance emerging. Is anyone in Uganda can prescribe drugs. I have people who are told that the drugs, I don't know if you've heard of Dexa. Yes. Dexa in Uganda is like food these days. A patient comes, says, doctor, I've been having back pain, but my MSA and the village told me I should be taking Dexa and an antibiotic. But this has nothing to do with back pain. Nothing at all. So, but it's a common thing. So, if there's a way the government would find a way of limiting who prescribes the drugs, and then also, of course, the issues of pharmacies, I think we should adopt a system whereby by the time a patient comes by a drug, there should be something to show who has written for you this drug. Maybe that can help, because anyone these days writes drugs. There is overdosing, there is underdosing, there is wrong prescription. Someone has malaria, they give you antibiotics. Malaria and antibiotics have nothing in common, but we see this a lot. Someone is given a testosterone, they add an antibiotic on top. And the word they always say is an infection. Infection becomes infection. So ask yourself, which infection you're talking about? Because in medicine, there is no diagnosis called infection. But I've seen this in the case of social media where someone goes and tells you, I'm sorry, young man, an infection. But for us in our training, we didn't have a diagnosis that the infection is not there. But it's very common. So it's because of having such pain practice work, I can't say not qualified, but maybe who didn't learn their medicine well, that we're having these problems here. Usually, as for me who works in Maine, the most advice I can give a patient is, in the main hospital, when you come, of course, here we're a bit understaffed. Usually, you find that there are more patients than doctors. One of the biggest problems is impatience. Yes, someone comes and they get, okay, what causes these diversions is impatience in hospital. Especially, and then there is desperation. Someone comes, they have a fracture, but they want a quick service. Here in Maine, it's a bit challenging, because in the orthopedic department now, we actually 3 doctors. There comes a time when you're all operating, but that doesn't stop people from getting accidents or breaking their bones. So people have come, but you are all engaged, because most of our surgeries need 3 people on table. So literally the whole department is now in one place, and people are breaking. So at that time, those are the gaps for use and say, the doctors don't exist, please let's take you somewhere else. But the whole issue is, you just have to be patient. And I think the whole thing is patience. The doctors are there. We may not get to you immediately, but we shall certainly get to you. That is the truth. At least we always, every day, every morning, every evening, usually even late nights, we always pass by. So we may not get to you in the hour you have come, but we always get to you. And usually if it's an emergency and you really, really need urgent care, they always let us know and we can reach you. Yes. Because even when you reach the emergency department, we have all our contacts with the orthopedic department. They are laid out. So in case you reach there and you feel you're not being attended to, there is no harm in calling. Yes, you call, you say, because for us, we pick all numbers, we don't refuse. You call and say, Doctor, I'm so and so, I'm in casualty, I have an accident, I need help. So if I can't reach you, I'll send an intern, or I'll call a colleague whom I think is free, who can attend to you, take care of the emergency, that by the time I come, you've been stabilized, and then I pick up from there. But usually the problem is, it's desperate. People are desperate and they are not aware that the service is available. We may not get to you immediately, but we shall surely get to you. Yes.
Okay. So the
one. And then 2, of course, there is failure to heed the instructions, because we have departmental meetings almost, I think, every 3 months, where we have laid out guidelines. When a patient comes, you're a clinical officer, this is where your training ends. When you see the patient, please do your part and let us know. But some of these patients I'm talking about are actually seen by these clinical officers who go ahead and do beyond what they're supposed to do. So by the time they come, the patient reaches you, the clinical officer has mismanaged the patient, and you know you haven't told the patient, because this clinical officer is under the department. He answers to you. So for us in training, when your junior makes a mistake, you can't talk to it about to the patient about it, because it is your job to supervise this man. But this is a man you told, please, when this happens, let me know. But he doesn't let you know. So you only actually, how you get to know is the patient realizes he has been mismanaged. Then he consultant tell him, no, but we have doctors who the bosses around. So you get to know the patient because the patient is pushing to see you. But you are the expert because he knows he has messed up, he's keeping the patient. He didn't want the patient to reach